Warm greetings to everyone. Today we will be delving into the topic HIV and periodontal with your presenter Dr. Radhika, Associate Professor from the Department of Periodontics, Chetna Dental College and Research Institute. Acquired immunodeficiency syndrome is characterized by profound impairment of immune system. The condition was first reported in 1981 and a viral pathogen, the human immunodeficiency virus, was identified in 1984. The condition was originally believed to be restricted to male homosexuals. Subsequently, it was also identified in male and female heterosexuals and bisexuals who participated in unprotected sexual activities or abused injected drugs. Pathogenesis shows strong affinity for cells of immune system, specifically that carry the CD4 receptor molecules, the T lymphocytes. B lymphocytes, although not infected, the altered function of infected T lymphocytes results in B cell degranulation and altered neutrophil function. Macrophage, monocyte, Langerhans cells, brain cells may also be involved. Mode of transmission. HIV is detected in most body fluids, including your blood, semen, vaginal secretions, CSF, breast milk, and urine. Common method of transmission: sexual contact, blood transfusion, needle sharing, perinatal transmission, occupational exposure, organ transplantation. Classification and Staging Centers for Disease Control, CDC 1993. Based on opportunistic infection and malignancy, presence of any 25 specific clinical conditions in a patient will confirm the diagnosis of AIDS. Commonly encountered is the candidiasis, cryptococcosis, cytomegalovirus disease, Kaposi's sarcoma, Burkitt's lymphoma, Mycobacterium tuberculosis, wasting syndrome. Most recent significant change: CD4 T4 lymphocyte count less than 200 per millimeter cube or less than 14% total lymphocyte is definitely for AIDS. This table shows the various CDC AIDS surveillance case definition conditions of HIV-associated diseases. CDC surveillance case classification in 1993. In that, category A includes patients with acute symptoms or asymptomatic disease, along with individuals with persistent generalized lymphadenopathy or without malaise, fatigue, or low-grade fever. Category B includes patients who have symptomatic conditions such as oropharyngeal or valvovaginal candidiasis, herpes zoster, oral hairy leukoplakia, idiopathic thrombocytopenia, or constitutional symptoms of fever, diarrhea, and weight loss. Category C includes patients those with outright AIDS as manifested by life-threatening condition identified by CD4 T lymphocyte level of less than 200 per cubic millimeter. Systemic manifestation symptoms include fever, malaise, headache, diarrhea, lymphadenopathy, hematological abnormalities, neurological disease, non-healing dermatological lesions. Oral and periodontal manifestation of HIV infection. Oral lesions associated with HIV infection can be broadly grouped as fungal, bacterial, viral, and neoplasm. Oral manifestation associated with HIV infection include candidiasis, oral hairy leukoplakia, atypical periodontal disease, Kaposi's sarcoma, non-Hodgkin's lymphoma. In addition to that, melanotic hyperpigmentation, atypical ulceration, viral infection caused by herpes simplex virus zoster are common. Periodontal disease associated with HIV infection are linear gingival erythema, acute necrotizing ulcerative gingivitis, necrotizing ulcerative stomatitis, necrotizing ulcerative periodontitis. Candidiasis. Most common in HIV positive patients, it's a opportunistic infection. It's a fungal origin. Four clinical presentation includes pseudomembranous, erythematous type, hyperplastic type, as well as angular cheilitis. Diagnosis will be microscopic examination of tissue sample or smear of material sprayed from the lesion. Clinical picture: in pseudomembranous, it is painless, sensitive, white lesion, readily sprayed from oral mucosa, palate, buccal mucosa. In erythematous type, it is clinically seen as red patches on the buccal or palatal mucosa associated with depapillation of tongue. Hyperplastic type, least common in buccal mucosa and tongue, resistant to removal. Angular cheilitis, commissions appear erythematous with surface fissuring. The next Next one is the oral hairy leukoplakia, which is asymptomatic keratotic lesion. Lateral borders of tongue affected. Vertical striations impacting corrugated appearance. Appears hairy when dried, caused by Epstein-Barr virus. The diagnosis includes biopsy lesion suggestive of old cell HIV test to be performed. Next one is the Kaposi sarcoma. It's a rare multifocal vascular neoplasm. Painless reddish purple macules or nodules in the mucosa is observed. Different from classic form, more aggressive lesion. Most common site of involvement are the palate and the gingiva. Virus designated as human herpes virus 8. Oral cavity may be first or only site of the lesion. Diagnosed based on the histological findings. Atypical ulcer and delayed healing. Non-specific oral ulceration in HIV individual, multiple etiology like lymphoma, Kaposi sarcoma, squamous cell carcinoma. HIV-associated neutropenia may be featured oral ulceration. HIV-infected patient, latent herpetic lesions and active stomatitis are seen. CDC includes mucocutaneous herpes present for more than one month as a sign of AIDS. Herpes simplex virus, Varicella zoster virus, Epstein-Barr virus, or cytomegalovirus frequently are derived from non-specific oral ulcers. Atypical ulcers more severe and persistent in patients with low CD4 cell count. Next one is a non-Hodgkin's lymphoma. Its most frequent malignant neoplasia caused due to Epstein-Barr virus, which causes growing mass generally on the palate, tongue, and gingiva, and its soon ulcerating and present area of extensive necrosis. Pain may not be present. Clinically, the mass may be erythematous, purplish in color with a bogey consistency. Next is the linear gingival erythema. Persistent, linear, easily bleeding erythematous gingiva may not serve as a precursor to rapidly progressive necrotizing ulcerative periodontitis, often unresponsive to corrective therapy, yet such lesions may undergo spontaneous remission. Next one is the necrotizing ulcerative stomatitis. Severely destructive acute painful present in HIV positive patients. Necrosis of oral soft tissue and underlying bone is observed. Occurs separately or as an extension of necrotizing ulcerative periodontitis and associated with severe depression of CD4 immune cells, mandible on cancrum oris or noma. Necrotizing ulcerative gingivitis, puncture crater-like depression at the crest of indented papilla with extending margin gingiva is commonly seen. Surface of gingival crater covered by great pseudomembranous log is observed. Crater is demarcated from the remainder by a linear erythema. Necrotizing ulcerative periodontitis is characterized by soft tissue necrosis, rapid periodontal destruction, and interproximal bone loss. NUT is present after the marked CD4 cell depletion and usually localized to few teeth. Bone undergoes necrosis and subsequent sequestration. According to study reports, susceptibility increases as immune system become more compromised. Injectable drug abusers, oral candidiasis, and meningeal erythema are seen. Diagnosis for HIV, immunological tests, total leukocyte and lymphocyte count, T-cell subset assay, platelet count, IgG and IgGA level, and lymph node biopsy. So specific tests for HIV infection, antigen detection, antibody detection, virus isolation, and serological tests. Screening for HIV, ELISA test enzyme-linked immunosorbent assay. Blood samples obtained and sent to lab, targeted antibodies linked to an enzyme. If target substance is in the sample, the test solution turns a different color. Confirmatory test is the Western blot test, gold standard, analytical technique used to detect specific protein in the sample of tissue extract. Periodontal treatment protocol. We should check for the health status, infection control measures, and psychological factors. Line of treatment, prophylactic treatment of opportunistic infections, antiretroviral therapy, vaccines, and psychological therapy. For candidiasis, early lesions, topical drugs can be given. For advanced oral lesions, systemic drugs should be given. The topical drugs are clotrimazole ointment 50 gram tube applied to the affected area. Systemic drugs are ketoconazole, fluconazole, itraconazole. For oral hairy leukoplakia, laser or conventional surgery is advised. Antiretroviral therapy, acyclovir, dodovidine, and lamivudine can be advised. Kaposi sarcoma, antiretroviral agents, laser excision, radiation therapy, intralesional injection, and other chemotherapeutic drugs are advised. Treatment of periodontal disease associated with HIV infection. First one should be the debridement with povidone iodine. Local antimicrobial therapy, fluoroxyl gluconate 0.2% can be advised. Immediate follow-up care should be taken. Systemic microbial therapy, metronidazole 250 milligrams 4 times per day for 5 days should be given. Non-specific oral ulceration and reflux abscess, acyclovir 200 to 800 milligrams 5 times daily for 10 days should be advised. Maintenance dose 200 mg to 5 times daily to prevent recurrence. Recurrent abscess ulcer, topical corticosteroid, flucosinodide gel applied 3 to 6 times daily. Large abscess, systemic corticosteroid, prednisone 40 to 50 mg daily. Infection control should include personal protection through vaccines, masks, and gloves, decontamination of used instruments, sterilization of instruments, asepsis of the operating environment, surface disinfection, aseptic surgical technique, post-operative aseptic technique should be followed. HIV vaccines, smallpox of HIV virus. The vaccines being tested should produce either antibody or cytotoxic T cells to fight infection. They can't cause HIV or AIDS. Types: peptide vaccine, recombinant subunit protein vaccine, live vector vaccine, DNA vaccine, virus-like particle vaccine.